This is Robin Elliott. I'm president of the PDF, and I'm my great pleasure to be recognizing you and welcoming you to this terrific call, which is going to be the first in our 2013-14 series of webinars on topics that are suggested to us, crowdsourced, I believe is the contemporary phrase, by the people who join these calls and live either with Parkinson's themselves or with family members who are also undertaking that challenge. This is a topic that is of great interest to everybody, the disabled community and all other communities. First time we've tackled it, and I'm thrilled to say that we have one of the world's absolutely leading experts on this to be leading the conversation today, Dr. Bronner, who I will introduce properly in just about a minute from now. A couple of business items. We have, first of all, I want to acknowledge the support for this program for this coming year, which has been very generous from the AbbVie Corporation. We designed the program. The AbbVie Corporation supplies much of the financial support that we need to put it on. We're very grateful to them for this. At PDF, for those of you who don't know us, we do many things in education and advocacy and in supporting research in Parkinson's. If you'd like to find out about any of these things going beyond the webinar today, please do visit us at our website, shortest domain name around, www.pdf.org, and you can learn about other items in the series and also other things that we do in this community. That is, I think, conclude. One other small piece of business. I know there are people on this call who are looking, expecting to get continuing education credit through the American Society on Aging. If there are those of you who are wondering about this, we are awaiting a contract. It should be in 24 hours from now. This should all be set. And those of you who have indicated to us that you're interested in this will receive an email from us 24 hours from now with the details as to how to access the link that you will need in order to register and get your credit. So please just be aware of that and be waiting for that. So I think without further ado, let me introduce then Ms. Bronner. She is, as I said, very distinguished person in this field. She has a master's in public health. She also has a master's in social work and is a certified sex therapist and director of the sex therapy service in the Sexual Medicine Center at Sheba Medical Center in Israel. She has been trained in Israel and also in the United States. She has a long and very impressive resume of publications and studies and leadership in this field. Because of her work in sex therapy, she was able to construct what she describes as a multidisciplinary approach to coping with sexual changes in people with Parkinson's and their partners. In a cooperation with the Israeli Parkinson Disease Association, she organizes training for health professionals, nurses, physical therapists, speech therapists, psychologists, and occupational therapists. The theory being, of course, that this particular facet of Parkinson's and of life in general needs to be played out through the work of the other professionals who take care of people in other aspects of their lives. And this is what she does preeminently well, and we're just thrilled to have persuaded her. It wasn't too difficult because she said she really welcomed the challenge to speak to us today. So no further ado, Dr. Bronner, thank you so much for joining us, and the floor is yours.
Hi, hello to everyone. So I'll try to cope with this complicated issue, not very complicated in my eyes, but maybe not spoken enough. Intimacy and sexuality in Parkinson's disease, making the impossible possible. And we asked you for feedback, for a survey, and it was great because almost 400 of you really gave us answers. And I'll try to actually quote some of you along my lecture. So one of the questions that we ask you is, how many of you do you have any problems? Do you report about experiencing sexual problems? Only 12.8 out of 351 respondents said they have no sexual problem. The others really had it. And then we asked them, Are you discussing it with your doctor? And as you see, about half, 49% never, in the blue color, you can see it, never discuss sexual problems with the doctor. And this is one of the problems, because when we have any other issue bothering us, we do discuss it with friends, we ask experts, we ask the opinions of others. And as to the women, will come later. Just a minute. These two slides, I'll come to them later, but these were also your responses. And when we ask you, do you think that women with Parkinson experience sexual dysfunction, actually many of you thought that they do have. About 60% thought that women have low sexual desire, and about half have difficulties reaching orgasm and problems with lubrication, which is actually arousal problems. So we do have a lot of problems. And in the next slide, you can see when we ask you, what do you think about various symptoms of Parkinson? The motor, the non-motor, how do they impact your sexual functioning? And as you see, the first place in the right column, you can see fatigue. Over 50% of you felt that fatigue is very affecting, very hindering in a way. And also some of the motor symptoms like muscle rigidity and clumsiness in your fine motor control. You can see that about 43%, 39% of you thought that these are really bothering. And if we add to this anxiety and sleep disturbances and depression, you can see that many of the Parkinson disease symptoms are actually affecting your life. So let's look at it from the beginning. Okay, let's talk about sex. Why do we talk about sex? First, because it is natural. It is natural aspect of life. Animals do it, we do it. And also it is long in the history, in the human history. I don't know if you know these coins, but if you look in the internet, you will see the sprintia. The sprintia are ancient Roman coins from the 1st, 2nd century. And actually they were used to buy sex service. And since people did not always want to say exactly what they want, or they want to be sure that they get exactly what they buy, you see that one side of the coin had exactly the invited position or the invited service that they wanted. And not only this history, but if you look in various places, for example, if you ever have visited India and you've seen the Khajuraho temple, and it looks great when you look from far away, but when you look at these specific details at the top of the temple, you can see that actually they depict sexual activities, various. And when we look at them, we realize that in the 21st century, we did not invent anything new. So why do we talk about intimate and sexual relationships? Do we have any benefits? And I say yes, we have a lot. Because being intimate or being sexual, and I will explain later what I mean and what is the difference, actually can give us emotional relaxation and physical relaxation, and even feeling better, increasing our self-esteem and our confidence and our vitality. And also it is pain relieving, because when we touch, our body excretes, produces specific neurotransmitters, which are specific chemicals, which act like medication, like relaxation medication, like morphine, and they are pain relieving. And also, being intimate is a way to express our gratitude to our partners. And it gives us better life, better quality of life, and increases our satisfaction. So it is something worth working on and finding solutions, either if we are in couple relationship or if we are single. So how do couples maintain intimate and sexual relationships? Actually, you have to invest in 4 domains. And it doesn't matter if you are in your 20s or if you are at your 90s. And these 4 domains include couple time, intimate time, emotional and physical, sexual time, and personal time. I want to start with personal time. Because if you are burdened with a disease like Parkinson, either if you have the Parkinson or if you are the partner who lives with the disease or accompanies the disease, don't forget that each of us needs personal time, which means to separate from one another for a short time, for a short period, just going to the gym, taking a walk in the garden, go for shopping alone, sit and have a bath for half an hour just listening to the music, looking at TV. We need our personal time. Because the disease demands a lot of attention, sometimes we forget it. And this is very devastating to your intimacy. And then what is couple time? Actually, couple time can be a lot of things. You can dance, you can enjoy each other's company, you can do things together, you can, whatever is possible, of course, whatever is accessible for you. And then, if we talk about intimate time, we divide it into the emotional one, which is talking and sharing and supporting and listening and loving and caring. And this is the moment that I want to use some of your tips. Because the last question in the survey that I mentioned at the beginning, in the last question, what I asked you is, do you have any tips for people with Parkinson and their partners for increasing their intimate relationship and for overcoming their sexual dysfunction, all those which are affected by the disease or by the treatment? And I must say that some of you really gave good advices, and I want to quote it. For example, one of you said, talk to your partner more and nicer. And another one wrote to me open discussion as to what both expect and discussing any negative and positive issues and planning and do it and share it. And I think it's very important. And another one of you wrote, make her, it is probably a male advisor, make her dinner, clean up, thank her for her enduring the support, and especially if she's just had a hip replacement, probably some personal experience. So we are talking about this intimate time, which is very important, and it is part of our sexuality and part of our intimacy. And then we have physical intimacy, which is touching one another, relaxing, having non-sexual touch. And many of you wrote about it, and you wrote about just hugging one another in bed, or just touching one another, just doing nothing, just lying one another near the other and sharing something. And these are very important issues because they broaden the concept of intimacy and sexuality, because sexuality is much more than only intercourse, and I'll refer to it within a few slides. And then, of course, we have the sexual time, which involves erotic thoughts or erotic touch, or trying to be excited sexually, trying to get sexual satisfaction, trying to have any sexual activity. So all these 4 areas comprise the intimacy and sexuality. But when I talk about sexual activity, what do I talk about? Most people will think of one thing, but let's look at the life of the animals. You will see everything. You'll see intercourse, oral sex, self-satisfaction, masturbation. You'll see everything in the life, in the wildlife. But what do we talk about when we talk about people? We talk actually about 2 things. One of them is intercourse. Probably all of you are acquainted with it. And this means sexual activity involving penile penetration into the vagina. This means that we need a good erection, and we need a lubricated vagina, which does not feel pain when something is inserted into it. And we need also to be able to lie near one another in a position which enables it. But sometimes we have some difficulties. And that's why we have other way of having sexual activity, and it is called the outer course. And what is outer course? This is sexual activity without penile penetration into the vagina. So it is less stressful, and it can enable you find a lot of positions and a lot of way of touching one another. And what does it include? It includes hugging, touching, kissing, erotic touch. And if you want to be sexually stimulated, you can use oral or manual or genital stimulation. And you can do it with orgasm or without orgasm. Because as we grow older, sometimes we lose the ability to orgasm. Sometimes we don't lose it, but it is more difficult to reach it. And I'm talking about every person who gets older, not only people with Parkinson. In Parkinson, we have other reasons. So are elders really sexually active? Let's look at the research. Let's see what do we know. So first, look at some ideas. I don't know if you know the film which is called The World's Fastest Indian. Anthony Hopkins was the main actor. And what he said, which is very nice, the beautiful melodies, can be also played with old banjo. And if you look at the old people, what can they do? I mean, their accomplishment. So Goethe, the German poet and writer, he completed his Faust at the age of 82. And Tiziano was still drawing at 98. And Toscanini still conducted an orchestra at 93. And Edison continued working in his lab until 89. And Benjamin Franklin wrote the U.S. Constitution at 81. So why not sex and why not intimacy? Just because people think it is very strange. So let's see what happens in the world. What do we know about elders and sex? So first, there was an interesting Swedish research where 98% of the Swedish men who were younger at the age of 50, 59 said sex is important. But when they asked, the researcher asked older people at the age of 70 to 80, they asked them, is sex important? 72% of them said yes. And 46% of them even reported that they orgasm at least one per month. And what do we know about the United States? In the United States, there was another study, and it was a study among 3,005 men and women. And they asked them, are you still sexually active? And 73% of them, at the age of 57 to 64, said yes. But what happens at the age of 75 to 85? Still, about 1/4 of them, exactly it was 26% of them, said yes, we are still sexually active. And at the age of 65 to 74, more than half said that they are still sexually active. So why don't we know about it? Because people do not talk and they don't report. And because many people will say, you are too old for sex. But today people are active. So let's see what are we doing, and let's try to make the impossible possible. So let's understand a little more. What do we have to cope with when we talk about Parkinson? First, we have motor symptoms. We mentioned them before. The tremor, the rigidity, the bradykinesia, the akinesia, gait problems, postural instability, speech disturbances, swallowing disturbances. So we have motor problems. But much more than this, we have non-motor problems. And I will not read all of them. I think you know most of them. Like constipation, like sleep problems, like sweating, fatigue, problems sometimes in concentration, in memory, depression, anxiety. I think you know most of them. So how do they affect it? But before we see how do they affect it, we have to know that for many people, sexual dysfunction is very demoralizing. It is very sad for them. And what do we know about partners of people with Parkinson's disease? When we ask partners, they also say we have problems. So the disease and the fact that you live with the disease does not only affect the person with Parkinson, but also the partner. And actually, in the latest researches in sexual medicine, today we call sexual dysfunction as a couple problem. Even if the man has erectile dysfunction, it's the problem of both of them. Even if the woman has a problem of sexual pain, it's the problem of both of them. So we have to look at both of them. So let's continue. And when we continue, just a minute, I'm moving to the next one. So what can we do about it? So first, I would like us to understand better how Parkinson affects our sexuality and intimacy. And then we'll talk about later, we have to look for advice. So let's inspect all the factors that are associated with sexual dysfunction in Parkinson. I mentioned already depression. What does it do? It may decrease desire, and when you see the initial ED, I mean erectile dysfunction. It can cause it. That's why we have to treat depression. But sometimes even the medication, the antidepressants, can cause some problems, like retarded ejaculation. RE is retarded ejaculation, meaning difficulty to reach orgasm. And sometimes the desire is decreased, and sometimes we have erectile problems. And again, I want to quote one of the tips of you clever listeners who really contributed from your knowledge and from your experience. And for example, one advice was that sometimes, I'm just reading sometimes the medication we take are the problem. Some anti-anxiety medication are well known to affect libido. And this is one of you who is writing it. Often there is a suitable substitute that doesn't have those side effects. So what I'm saying is really consult the person, the professional, who prescribed you this medication and see if you can have another one or use it in a different way. Let's go further. What do we have? So we have motor disabilities, which really give you problems in arousing, in touching, in masturbation, in finding positions. It's not easy. And for example, for position, one of you also referred to it, and what did he say? Try different positions, different times of the day. Just go with it. Go with the flow. Be flexible as possible and talk about it. So we have your answer. Actually, you don't need me. I mean, most of you know these things. And then what else do we have? We might have loss of concentration, meaning that we have to use the time of the day when we are not too tired and it is easily for us to concentrate. And also we have to understand, you can see in the last two rows of this slide, the role changes. Sometimes it's not easy. If you have been all your life sexually passive, letting your partner be more active, sometimes you have to change the role. Changing roles is not easy, but it can be done. And what other factors are there? We have the problems of female sexual dysfunction. And as you remember in the beginning, we mentioned it in the survey. So the female can be the partner or the patient itself, and the women can have problems. We have also other problems like urinary problems, incontinence, fear of incontinence, and you can consult your doctor what to do. Sometimes you don't drink 2 hours before having sex. Sometimes just go to the toilet and visit, and sometimes you might need any kind of professional help for this. But ask about it. Because of urinary problems, it is quite silly to stop having sex. We have just to find some good advice, I would say. And then we have the chronic dopaminergic treatment, which can increase the desire, which can make things better or worse sometimes. And then we have the problem of the mask face, that some of us look as if we are not interested. And maybe you can consult with your physiotherapist or with occupational therapist and try to find some exercise for the face muscle, just to be more, to give the feeling that you are in it and that you are participating there. And then when we go on, we have the sleep disturbances. And this is not easy because sometimes you have to separate beds. And when you separate beds, then you have actually to change the technique of being intimate, because you have to prepare for yourself for a date. Sometimes you invite your partner for a visit in your room and get ready because you have a visitor. So prepare yourself and prepare the room. And communication is also problematic, especially when you have problems in talking. And if you cannot express yourself and you have really speech problems, then you can tell your partner a lot of things in another way. And I would like to suggest, for example, prepare some notes and write, "I love you. Darling, would you like a cup of coffee or tea? Or yesterday it was great." And you can prepare notes like this that you will use again and again if you cannot talk. Or go to the speech therapist and see if you can do something. And then we have all these changes, like sweating, like changes in walking. And also here, I must say that I got a very nice tip of one of you. And what he said is, he or she is very simple. Bring a towel to the bed to wipe up the sweat. I mean, as you know, I'm talking here from Israel. It is very hot and wet and humid. And we need towels always, when we have sex and when we don't have sex. So it is very easy. The solutions sometimes are really simple and easy. When you do have pain, this is a problem, because pain usually decreases desire and arousal. And pain demands sometimes to find positions which are not painful. And chronic pain is a problem in Parkinson, so we have to solve it. And we have to find what can be done. And if you get medication for your pain, plan your sexual activity within the period when this medication is effective. So sometimes you have to do changes, and being flexible is very important. And now I would like to refer to something that usually we don't talk much about it, the impulse control disorders in Parkinson. So we do talk about the problem that sometimes it is associated with the dopamine treatment. We usually talk very openly and very easily about pathological gambling, compulsive shopping, about compulsive eating, maybe medication use, but we don't always talk about compulsive sexual behavior or about hypersexuality. And this is very important to talk about it. And now I'm talking to whoever listens. If you are a person with Parkinson and your desire creates problems, or your sexual behavior creates problems, ask for help. It is silly to suffer from it. You should enjoy your sexuality, not suffer from it. And if you are a partner, talk to someone about it. And if you are a professional who knows about it, check where you can think, where you can find how to react to it. But there is one problem that I want you to know. Some people do not distinguish between hypersexual behavior, which is not correct, which is part of the impulse control disorders, And they don't distinguish this and normal sexual disorder. And I want to give you an example because it is very important. And I'm describing one of my clients. So I had a couple, and the man tried to have sex. But he had erectile problems. So he tried on the first day, and since he had erectile problems, he was not satisfied because he could not have the sex as properly as he expected. So on the next day, he tried again. And on the next day, he tried again. And on the next day, he tried again. And every day, he tried again and again. And after some time, his partner was sure that he is hypersexual. And when this couple came to me and we found out that this is only a problem of erectile dysfunction, which was not properly treated, and the moment it was treated, the frequency of the sexual behavior was reduced. So you have to know that not every behavior that looks like hypersexual is a hypersexual. But when the behavior is not controlled, and now I'll go to the next slide, just a minute. Now these are the frequency. I'm going to the next one, just a minute. And we are talking about behavior when you are always preoccupied with sexual thoughts, or always have constant demands, or you see promiscuity, habitual use of phone sex lines, internet pornography, contact with sex workers, sometimes even rare behavior like obsessive masturbation, exhibitionism, pedophilia, zoophilia, really rare behavior which we don't expect. And especially it is important that this behavior did not exist before. Because if this behavior existed before, it is part of the person's features. And the Parkinson maybe brought it out more clear. But usually in Parkinson, these behaviors did not exist like this. So then we have to know that we have to treat it. And I'm really asking you to look for someone who will talk to you about it. And I can tell you that I received a mail from a person with Parkinson from the United States who told me that he wrote that he is 68 years old and he has Parkinson 15 years. And what he says, that the medication, he feels that the medication made him, turned him into a sexually obsessed person. And it destroyed his marriage and his relationship. And he feels so guilty about it. And the worst thing, he says, that everybody is talking about gambling side effects, but nobody is talking really about sex. And nobody gives good advice about it. So I call you as consumers, as clients, ask your health professionals for advice. They should treat you, and they should react to problems like this. Now, these problems are rare. They are not frequent. But when they exist, they are really terrible. They are so devastating that we have to treat them. So we go on. And when we go on, we have to think, what can you do? First, understand that sex counseling is your basic right. Choose a healthcare professional with whom you feel comfortable. If your healthcare professionals dismiss you with mocking at you or disregard your questions, find another one. And discuss the problems all by yourself or invite your partner with you. What else can you do? You have to know that you have sexual rights. And what are these sexual rights? This is the right to love and to be loved, the right to touch and to be touched, the right to share intimacy, to remain human sexual beings. And this is not something that I'm telling you. The World Health Organization has a declaration on sexual health, and they say that people should have the capacity to enjoy and control their sexual and reproductive behavior. And not only enjoy and control, but it should be in accordance with your social and personal ethics. So it fits your personality, your family, and you have to be free from fear or shame or guilt, and also from organic disorder and disease, as we can do it. We cannot free you, but we can assist you. So this is something which is actually important. So what can you do? You can plan your sensual activity. Plan the time. Don't do it at the end of the day. Do it when you are very vivid. Plan your sexual activity. Learn how to touch one another in erotic and non-erotic way. Not every touch should be intercourse. Not every touch should be outer course. A touch can be just for feeling good. Communicate. Really talk. It's not easy. It will be very embarrassing in the beginning, but do it. Talk about it. Just talk. And actually, at this moment, I come to the question and answers, and I end the lead of this talk to you, Elliot.
Thank you very, very much, Gila. And just a terrific overview of one of the most important topics we could be discussing in connection with Parkinson's. We have, as won't surprise you, a whole variety of questions from all different quarters, and I've tried to combine these in some reasonably sensible way. First of all, one of the things you did not address directly, but interests several of our communicants here, is the issue of gay sex versus straight sex. Would you...
the case of?
I'm sorry?
Can you repeat?
Yes, the issue of gay sexuality and straight sexuality. The question as to whether the kinds of things you were talking about, which were primarily concerned, your examples were mostly of heterosexual relationships, whether the same or slightly different principles would apply in the case of
the same. I apologize that I didn't say. I was so excited for this, and I forgot this is an automatic thing I say in the beginning. What I usually say in the beginning of a lecture is that whatever I say refers to any kind of relationship, meaning men with women, men with men, women with women, or a person by himself. But since the majority are couples consisting of a male and female, and it is too complicated to mention all of them, what I usually say in the beginning is that I refer to everything. So I do apologize that I say it in the end and not in the beginning, and thank you so much to everyone who just remarked this.
No apology necessary. That was a very clear statement, and I think will be very direct for those who had raised this. Here's a question about drugs, and you did allude to this in very clear ways, but I'm struck by two questions which come in, one from both in the United States, one from Florida, and one from New York. And it has to do with the medications that are prescribed for Parkinson's, some of which we know can create, as you pointed out in the latter part of your talk, compulsive behaviors, including, in some cases, compulsive sexual behaviors. But in some cases, there was this question from New York, there was a question as to whether the medications might actually depress sexual interest. So it's sort of, you did allude to both, but I wonder if you could clarify a bit more. In your experience and knowing the medicine, though you're not yourself an MD, you certainly know this general topic so well. Are the medicines that are more inclined to increase sexual interest and activity, and others that are likely to depress it? Is there a way of generalizing in those very different kinds of behaviors?
Since I'm not a physician, I'll just answer very generally. So first, you have to know that every disease that you think of, let's say a person who has a cardiac problem, or a person who has hypertension, or a person who has diabetes, or a person who has Parkinson. Every person who gets medication can either decrease or sometimes increase. Most of them will decrease, and in Parkinson it is the same. Most of the medication actually negatively affect sexuality. just for few people, a very low percentage, as I mentioned, something between 1 and 4% of the people with Parkinson react with impulsive control disorder, and usually it's not one kind. Usually they come in pairs, like gambling with sex or shopping with gambling or something together. I would advise any one of you who starts a new medication to check what happens to your sexuality. I mean, I'm talking on this side effect because this is the topic of our lecture. And if you notice any changes, as soon as you notice, consult with your physician. It will help both. First, the physician will learn much more about it, because if we do not say, we do not share, we don't complain, they don't know. And if we share, they have to act. And I would like you, as people with Parkinson, to be the power which changes the attitude towards sexuality and intimacy. And you can do it.
Thank you. You spoke, Gila, about the different kinds of symptoms that can be associated with Parkinson's that
Yes.
can interfere with sexuality and sexual relationships. And we had many questions of that kind, some of which you mentioned and addressed directly, one of which, or two of which, I don't remember you addressing. So I'm going to ask the question, because it is of such great interest to people. And examples are, from Tennessee, there's a question of tremors, which in this relationship make a real problem for the female partner in the relationship. From Massachusetts, there is the problem of incontinence, which you also did address specifically, and that can obviously be very interfering. From Pennsylvania, there was a question about drooling, which is very commonly associated with Parkinson's, obviously, and can also interfere. And from Iowa, a question that I think you did not address, which was the cognitive problems, which in this particular relationship, cognitive
problem?
Problems of memory and
memory.
Problems of cognitive function. That
yes,
part of
right,
which can sometimes come with Parkinson's, and that is the issue. Because it is so common, even though you addressed this directly, some of these directly, could you give us a little more kind of color to this? What kinds of ways, what generalizations could you make as a very experienced therapist for people to address, understand, be patient with, or deal with this very wide range of potential problems with Parkinson's that interfere directly with sexual experience?
What I say is it's like experimenting. For example, the tremor or the incontinence or the drooling or the memory problems, cognitive problems. Why I'm saying experiencing? Because usually what we say that if we have a problem, we have to check if this problem is constant during all phases of the day. Is it constant every day? Is it more obvious when we are more nervous or more relaxed, or after rest, or when our relationship are calm, or when our relationship are stressed? So what I'm saying that usually when couple or a person by himself come to me and complains, I will try really to analyze the description of the problem and the timing and to what kind of issue it is connected, okay? And sometimes we find really the solution very naturally, okay? Now, what do I mean? If you have good relationship with your partner, then just try to lie, if it is okay for both of you, to lie hugging naked or with close to one another at various times of the day and see what happens. Tremor sometimes increases when we are excited, for example. So this is a problem, because if you try to hug your partner and your hand is moving, then we have to use something. We sometimes recommend our patient to use some material which separates between our hand and our partner, and the material can be a nice silk clothes, piece of clothes, but it can be also, we have now gloves which are made from very modern fabrics, like all these microfibers, or all these materials that they make from them, very nice winter clothes and winter coats, and they are in various materials, and they just the tremor is reduced through the use of the material. As to incontinence, I would consult with a urologist, because this is really a problem. I don't know if your neurologist is expert in urology. Some of the neurologists are expert in urological problems, but many of them not, and we need really a urologist. And then if you ask about the memory problems, the question is, how does it affect? Because sometimes memory problem affects concentration. So we have to find the time of the day when you are more alert. Sometimes cognitive memory changes are positively affecting, because we forget very quickly what made us nervous. So we have to see what are the advantages of things. For example, one of you wrote in his, I remind you the tips that I received. Actually, I received 65 tips. It's a lot. So one of them said that for this couple who wrote it, they say tremor can be very good. It can be used positively for clitoral stimulation. So this is what they found, but for some other it is disturbing, so we have to think of other solutions. So actually what you have is to be, I ask you something maybe which is difficult and challenging. I ask you to be flexible, and I ask you to be creative, and I ask you to be patient, and then you find it.
Thank you, Gila. Thank you very much. A couple of sets of questions, one involving men and one involving women. For the males, we had several questions about medications that address the problems of libido, in particular Viagra and the other drugs that are very similar to that increase male stimulation.
Okay.
What is you didn't mention that among the medications. I wondered if there's anything particular.
Yeah, it's a good question.
Mm-hmm.
And the women asked the same?
No, the women actually, well, not the way I chose them. They could have, but maybe. Well, why don't we begin by having you answer it that way, with the women and the men,
so,
and in both cases,
first I have to make it clear that all these PDE5 inhibitors, which are erection dysfunction medication, like the Viagra, the Cialis, the Levitra, they are not usually stimulating desire. They are affecting the arousal, meaning the erectile function. And I'm so happy that you asked this question, because you have to know one thing. Due to autonomic problems, which make the absorption of food and of medication slower than usual in people with Parkinson, you have to take into account that when you use this medication, you have to wait much longer than the doctor usually tells you. Because if a person takes one of these medications, usually they tell them to wait between half an hour to an hour, and then begin with some intimate erotic activity in order to get into the proper mood. And when you are in the proper mood, the medication can affect your erection positively. But when you have slowness of the gastric system and the absorption of the medication is much slower, it means that if you wait an hour, you will not succeed. And you will try again, and you will fail again. And then you will come to your doctor and you'll say it doesn't work. And my advice is, make a personal experiment and see how much time do you need for the effective absorption of these medications. My patients, for example, with Viagra, some of them need 2.5 hours or 3. With the Cialis, some of them need 4 or 5 hours. And since these medications stay in your body between 10, 12 hours to 36 hours, it depends on the medication, there is no problem in waiting. There is problem when we don't wait, and we are so frustrated that even medication do not help us. So
very helpful. Thank you.
Yeah.
Two questions concerning the female challenges. One has to do with rigidity of vaginal muscles, and the second, which has to do with dryness in the same area. The question is, are there ways in which either or both of these can be addressed to improve sexual
You mean a rigidity of the vagina?
Yes, the vaginal muscles.
The genital muscles, yeah.
Mm-hmm.
Okay. What we have to know is two things. One, is it really the rigidity, or is it a problem of aging when flexibility of the vagina is changing? So we have two options. Either shift from intercourse to outercourse, and then you don't have problem with the vagina, or you have to go to physiotherapists, and physiotherapists, but not those who are dealing with walking or with your postural, with your gait problems, but we have physiotherapists who are dealing with pelvic area. They are specialists in pelvic area. You can come to them with question of incontinence also, but also with rigidity of the muscles of the pelvic area, and they can work with you and see what can be done. Usually there are methods of biofeedback where you work with your muscle and you see on the computer screen, you can see how much you relax and how much you contract the muscles. So actually what I suggest are two things. When you suffer from rigidity, try to find a solution, and until then, don't stop having intimate relationship, but leave the intercourse and shift to outercourse until you solve the problem, of course.
Thank you. Here's another question that I don't believe you addressed, but many people ask it. Physical exercise. Does physical exercise help with the problems of sexuality and sexual relationship that can come with Parkinson's?
Physical activity helps everyone for his sexuality. I'll tell you why. Because one of the things that we need, or the few things that we need in order to be sexually fit, we need a good blood flow in our small, very tiny arteries, which consist of blood supply to the pelvic area, but also in the big areas, I mean the heart and all these big arteries, and doing exercise help it. In addition, we need good neurological connections, I mean the nerve system. And when we do physical activity, our nerve system usually is better, is more effective. Then, if we do physical activity, our body usually, when we do any physical activity, our body produces neurotransmitters which make us feel better. They make us feel more relaxed, less stressed, less anxious, less depressed. So actually what you do when you do the physical activity, you increase the effectivity of your body systems. You decrease some of the symptoms which you suffer from them sometimes when you have Parkinson. And actually what I would do, if it is possible, if you are in couple relationship, invite your partner and try to do some of the activity together and turn it into your couple time. So you have another benefit.
Thank you. Here's a question from the country of Colombia. The person asks about possible additional means of stimulation, the use of sexual toys, the use of cannabis or marijuana to help arouse libido? Or in the same category, I suppose, would be any other kind of stimulants that can be used to help the relationship. It's one of those things, Gila, that to me seems something that is both a general question rather than specific to Parkinson's. But I think either way, it would be very useful to hear you answer it.
Yeah, I think that when we get older and when we live a long time in the same relationship, sometimes we need extra stimulation, to feel better. And reading sexual material or talking about sex or watching something, using lubricants like touching the body with some oily lubricants or oily massage oils, which give us, adds to the atmosphere and also to the feeling, and also can overcome some tremor or some rigid movement. Of course, it helps. Sometimes using vibrators is very important. And for male, sometimes we have vibrators which enable them insert into them, especially when you have limited ability with your movement, with your hand movement. And sometimes it is good for the female sexuality. So we can use vibrator for the genital area. We can use also vibrator for the whole body, like vibrating massagers, and whatever can be done. As for cannabis, there is actually a good research in Israel that it helps, but usually they use it when there is a problem of pain, and they don't use it for sex. I don't know of research that has been done in this area. But I would say whatever, if you, for example, drink a glass of wine and it makes you feel better, use it. Whenever you exaggerate with all these kind of drugs, which can be alcohol or other drugs, they can be legal or illegal, whenever you use them and you exaggerate, you lose. You don't get the benefit of it. So we have to be clever when we use these things. But it is interesting to use AIDS because many people, maybe even some of you, I cannot discuss this issue, but maybe some of you are disgusted or you feel very negative when you hear about using AIDS. But if you think about your life, don't you use AIDS? Don't you use a mixer? Don't you use a cutter? Don't you use so many devices to help our life? I mean, in the kitchen, in the living room, in the car. So why don't we use it for sexual reasons? I would say just the same as I said before. Try to be creative and try it. And if you don't like it, don't use it.
A very wise, very gentle and thoughtful response. Thank you very, very much. I think we have time for one more. I'm going to combine, as I have been doing, two kinds of questions here. And they have to do with the person you can go to for help. And the first question of this kind is, do I need to see a sex therapist, somebody of even half the experience of Ms. Bronner, or can I go to a general doctor or my Parkinson's doctor or some other kind of doctor? What would be your view of that? And then I have another related question, which I'll ask you after this one. So who can one turn to?
Okay, and there was one question that I received through the survey, and maybe I'll refer to it later. It's about dating, new dating when you have Parkinson. So maybe we'll shortly.
Good.
So first I'll talk about who can you apply to. So actually you have a variety of professionals, and it depends on what is the problem. For example, physiotherapists and occupational therapists can help you with movements, with finding positions. Maybe they have never talked about it or thought about it, but you can challenge them. Some of them will be very open. You can go to the urologist or to your family physician for medication for erectile problems. if you are the woman partner or the woman with Parkinson, you can go to your gynecologist when you have problems with your vagina or your pelvic area. The gynecologist can offer you lubricants. The gynecologist can offer you also local hormonal treatment. For you, the man, sometimes one of the reasons for being tired or feeling apathy or feeling very low sexual desire, sometimes one of the reasons is just low testosterone due to aging, not even due to Parkinson. And maybe you have to do a blood test. And this, again, you can ask your family physician, your urologist, or endocrinologist. I just don't know which doctors you are in relation to. You can write to me. If you write to me, you'll find my mail, Gila Bronner. You'll find my mail in the Internet. I will answer you. If I don't answer quickly, it means that I give a lecture or a workshop somewhere in the world. I'll come back home in 1 week or 2 weeks, and then I'll answer. So don't be disappointed. Be patient with me. Then in the United States, you have the organizations which all the sex therapists and counselors are members in this organization. And this is the ASEC. The ASEC, I will spell it to you, is American Association of Sex Educators, Counselors, and Therapists, meaning AASECT. And if you open the Internet, you can find members in your area. So you can look for sex therapists in your area. Some of them are not that expert in sex therapy, but since many problems can be solved by any sex therapist, and they don't have to be specialists in Parkinson, some of them you need a specific advice. So try and use any of these. Just don't hesitate of using it. And the question that I received was about dating in Parkinson. And actually, I was asked about how do you date, meaning could you address PD and dating? And actually, yesterday, I had a woman in my clinic here in Israel, and she asked the same question about dating. And she asked it more specific, do I have only to date people with Parkinson's disease? And I think that it can be easier because you have someone who understands you, but I don't think that this is the case. I know that it is a problem because when you have some kind of disability which is seen, which is clear, it's not hidden, because many people have disabilities, many people have problems, but some of the problems are hidden. You don't see them. Only when you get to know the person better, then you know more. And in Parkinson, sometimes it is obvious from the first, second meeting. So actually it is a problem because we have to find someone who can accept us as we are. Now, I don't know about things like dating on the Internet, if you have specific sites for people with some physical problems or not. So this one I don't know. What I usually suggest to people who come to my clinic is to join activities of the association that the Parkinson's Disease Association, like yours, Parkinson's Disease Federation. If you have meetings, if you have clubs, if you have lectures, maybe weekends, maybe seminars, and these are good places also to meet people. So we have to do it usually socially. It's not easy, but this is what we can do.
Great.
So I am ready for your next question.
Thank you, Gila. By the way, thank you so much. You were so generous to invite people to be in touch with you. That is very thoughtful and generous, and I'm sure we all appreciate that.
Yeah, as I told you, until I train enough professionals around the world, yes, I have to be the one to answer.
Well, it's really wonderful. Just the last question we'll do, and we're already over time. People, I hope, forgive us on this. Question that somebody asked that I'm sure is in a lot of people's minds, because of the delicacy of the subject of sex for many of us, Do you find that it is better for men who have questions to speak to male therapists, for women who have questions to speak to women therapists, or doesn't it matter?
Well, it doesn't matter. Some men feel better to talk to women. It is easier for them. They feel that the female therapist is more empathic. Some need the same gender. But actually what you need is a good sex therapist. The moment you have a good sex therapist, you forget if this is a male, a female, a young person, an old person. It doesn't matter at all.
That's wonderful. A great way to end.
And you know what? I'll add something else. If you go to a health professional, a sex therapist or another, and you don't feel comfortable, find another one. Mm. Especially when you talk about such delicate matter. You have to feel that the person in front of you is not judging you. Yeah. Is really interested in understanding your question or your problem and in finding a solution.
Wise
this is
words.
what you have to judge.
A very, very nice way to end, and thank you so much for this. I have a few other business matters before thanking Ms. Bronner and letting you all go back to your lives. First of all, I just want to alert you that an archive of today's event will be available for you to hear starting next week, a week from now, Tuesday, September 17th. You can access it through www.pdf.org. And since we know who you are, those of you who have registered, we're going to send you an email when it's available so you can listen to the talk again, or if you've especially enjoyed it and somebody you know couldn't make it for this live session, you can let your friends know about it. I want to alert you also to the next webinar in our series. It will be on Tuesday, November 19th at the same time, which is 1 p.m. U.S. time, Eastern U.S. time, and it's going to feature Gwen Vernon, who is a very, very high up and a very expert person in the nursing profession, the University of Pennsylvania, along with a person who is a long-time caregiver, and they'll be speaking on the subject of caregiving and Parkinson's, one of the, of course, the most enduring and important and difficult subjects of all. So I hope that you will be available for that and that you will let us know if you register if you wish to be part of it. We do ask people to fill in the survey. We do use our surveys. If our system's working well, the survey should be up on your screen at this moment. Please, before you tune out, take the opportunity to fill that in, complete it, and then we'll be using it, you can be sure, for all sorts of purposes. Most important, planning and improving our programs for the future. So please take advantage of that. And finally, before thanking our guest, there are many questions. I'm afraid I'm aware of this because I'm sitting with many of them around me on the table that we were not able to answer. If you were one of those who did not get the question answered, please accept our apology. There's no way we can take them all in this time. But we do ask you to come back in to call us on our 800 number and to speak to our counselors. We have a full-time counseling service at the Parkinson Disease Foundation with expert people who know a great deal about Parkinson's and some also about this subject. And they will be very pleased to take your questions, and if they can't answer them themselves, they will refer to someone like Ms. Bronner to help them with this. So call us at 1-800-457-6676 and ask for our helpline, and we will be pleased to then answer your questions at that time. So, Ms. Bronner, thank you very, very much for this terrific talk. It's the first time we've done this. I don't know why it's taken us so long, but I'm so glad we have done it, and we couldn't have had a better exponent of such a difficult and, as you say, a delicate topic, and so beautifully handled with such expertise and experience. Thank you so much for this.
Thank you so much for the opportunity.
And thank you, all of you, for joining us today. Talk to you soon, later. Give us a call anytime. Take advantage of Ms. Bronner's very generous offer if you care to, and talk to her directly, and have a very good rest of week and month and autumn season for those in the Northern Hemisphere. Take care, and goodbye for now.